Copy. All right, I'm just setting the link up for everybody over there to watch with us who wants to. There we go. That's now on our Facebook. All right, so we are live. We are rolling along. So we've already gone through several of these, but we're going to keep moving along and talk about this. But we're going to start with our system changes postpartum. Okay? So we're going to start with hematologic changes. What happens after labor, after birth, to our blood volume?
Decreases.
Right. It decreases. We have blood loss due to labor and delivery, and what else do we have? How else do we lose our volume?
Diuresis?
Diuresis, right. Remember, if we're using Pitocin specifically, it's very chemically similar to several other things that make us urinate a lot. I'm not going to put too much into this. We're going to be getting rid of a lot of fluid. We have a lot of IV fluid going into these patients. We have a lot coming in during labor. So now we're going to get rid of it up to 3 liters a day. White blood cell count is increased in the next 5 to 6 days, and fibrinogen will be increasing. That returns to normal in 3 to 4 weeks. What about our hormone levels? What happens to estrogen and progesterone after pregnancy?
Decrease.
They decrease, right? However, we still have a certain hormone that's being produced because of breastfeeding. What is that?
Relaxing.
And oxytocin.
Oxytocin is going to be doing, and prolactin for the lactinogenesis. It's going to make you very sleepy more than likely when you're breastfeeding. What about HPL, cortisol, HGH, insulinase?
The decrease.
They're all going to be decreasing. Now, what about diabetics? Especially right after their pregnancy, they're going to go into a honeymoon phase. What is that?
Their insulin levels will decrease, or the amount of insulin levels that they need will decrease.
Yeah, the amount of insulin they need will decrease. So if they have a pump, we have to make sure that they're changing their setting and dropping that setting, because they could go hypoglycemic if they're not careful. Neurological systems, we've got altered sleep patterns. Mama's going to be tired after all this. It's hormone changes, and there's a new baby. Of course, we'll have our risks for fatigue, etc., as we go further into that. Now, neurologically speaking, we're getting everything back in order. There's going to be issues due to an epidural or anything that we use to actually, like a spinal block, to stop that pain, right? In general, though, we're going to have that general dizziness as we're dropping their fluid levels. Our legs are going to feel numb. What are we worried about at that point?
We don't want her to fall down, especially while holding the baby. She's got to get her bearings.
Right, safety for mom and infant, right? Mm-hmm. But that it's normal for postpartum to feel that those numbness and that dizziness. We have to make sure that the mom takes time to sit up, feel her, get her bearings before she starts grabbing onto everything. Headaches. What are we worried about?
Blood pressure?
Blood pressure? Yeah. What can happen postpartum still?
Preeclampsia.
Preeclampsia can still happen postpartum. Therefore, eclampsia can still happen postpartum, right?
Mm-hmm.
We still go into seizures. We don't get enough. Let's see. What other things could happen, especially if they had an epidural or any sort of hole put into their spine?
The spinal headache.
Spinal headaches, yes. If any sort of headache or pain occurs, assess the situation. Where is it occurring? How is it occurring? How much does it hurt? Or 0 to 10. The type of pain. Is it burning, stabbing, continuous? Is it come and go? Intermittent? And of course, our environmental interventions, especially if it's spinal, decrease the light and sound in the room. If it's an issue with preeclampsia that may lead into that, we want to decrease the light and sound in the room. We may need visitors to go home to actually decrease the sensations. Now, renal system. What's going to happen to our GFR? Creatinine, BUN.
It's gonna go down, isn't it?
Our filtration rate, creatinine, well, they're all going to get back to normal within 2 to 3 months. All of these will be back to normal within 2 to 3 months. The idea is they're abnormal in pregnancy. You have urinary glucose checks, which would tell, and we have proteinuria, which would tell us what if you have proteinuria.
Preeclampsia.
Preeclampsia, hypertensive issues. And then, of course, we're going to have rapid sustained natriuresis diuresis, our urination, and they can reach as much as we said 3,000 liters a day. 3,000 milliliters a day. 3,000 liters. 3 liters. All right, respiratory systems. If somebody's multigravida during their pregnancy, they're going to have an increased HCG, right? The normal. Yes, no, maybe.
Yes.
Yes.
What does that give them an increased risk of occurring most of the time?
Preeclampsia.
HCG, just HCG.
Hyperemesis, whatever better.
Gravidarum. Yes, they're going to be throwing up a lot more.
Double the pleasure.
Yes, so lots more throwing up, which leads to what disorder? If it's not taken care of.
Hyperemesis.
Hyperemesis gravidarum.
Yep.
So we have to think about that as well as we're going through this. But now we're going to move on to our respiratory system. We've got this patient's been breathing very rapidly for a while. What do we think is happening respiratory-wise? Are they acidotic or alkalotic?
Alkalotic.
Alkalotic. Where'd the CO2 go? They breathe it out. And during labor, they're probably going to have compensated metabolic acidosis. And this can go into the postpartum period. Will this take care of itself as they calm down and come out of this?
Yes, it should.
Yeah, it should take care of itself. It's mostly related to that altered breathing pattern. We've got we've got the respiratory alkalosis, so our body kind of compensates for that with the metabolic acidosis. pH shouldn't be changing necessarily. Hopefully. All right. What about intra-abdominal pressure? Are we going to be able to breathe better after labor?
Yes.
Yeah, we have a decrease in that. We'll have relief from that dyspnea. We've got our integumentary system changes. We have all about the lines, striae gravidarum. We have our stretch marks. What other integumentary system changes would we have?
The facial color.
Facial melasma.
Facial melasma, also known as cloasma, right? Our mask of pregnancy.
No linea nigra.
Most of these will disappear. We have to educate again on mom, though. It takes time. And what about the abdominal muscles?
Exercise.
Modified sit-ups, right? Exercise. Kind of sit up, push them together.
Because they're not going to go together on their own.
It's going to take time and work to get them together. What happens to striae gravidarum with time?
It lightens up.
Lightens, silvers up. Yep. Cardiovascular system. We've delivered the baby. We've gotten rid of the placenta, and we've lost a whole bunch of amniotic. We've lost all the amniotic fluid, hopefully. So we've gotten rid of all of that. What would happen to our heart if all of a sudden we drop all that fluid? What happens? What happens to our heart normally if all of a sudden we hemorrhage?
Oh, it's going to get faster if you're hemorrhaging.
Our cardiac output's going to increase for about 48 hours postpartum. Our cardiovascular instability during immediate postpartum period, all this loss can create cardiovascular instability because we're all of a sudden losing a whole bunch of fluid that was there before. Our cardiac output goes up, for about 48 hours. And we have our physiological diuresis at this point. Between the 2nd and 5th day, major fluid shift into the venous system for diaphoresis and diuresis. Let's let it out. We're going to pee it out. Body's trying to get everything back to normal. Okay. Let's do blood. Immune system. If mommy is Rh positive, when would she get the Rogaine shot?
If baby, never.
There we go. Never. Never. If baby is Rh negative, when would mama get the Rogaine shot?
Never.
You want to?
Baby has to be positive.
She may get it prophylactically, though, right?
Oh, if it's
If mommy is Rh
negative.
negative, we don't know the data on the baby, and it hits 28 weeks, we may be giving a prophylactic at 28. But then we wouldn't give that post-birth, right? Because we figure out, oh, baby's negative too, you don't need the prophylactic. You weren't actually introduced to it. Watch those.
Yeah.
When would we not give an Rh negative mom Rogaine if the baby's Rh positive?
The mom's sensitized.
Yes, if the mom's already got the antibodies. All right, rubella vaccination.
Ella.
Ella, Ella, hey, hey. All right, what about the rubella vaccination is special?
Something about they can't get pregnant a month after, is that right?
Yeah, for about a month, depending on the source, 1 to 3 months, because it can affect the pregnancy. Also, right after labor, if she's not immune, she needs to get that vaccine unless she refuses. She'll have a signed consent form. With that, she could get flu-like signs or symptoms. And she needs to make sure not to get pregnant for that month, so contraception. Is breastfeeding a viable form of contraception?
No.
No.
No. It may help, but it's not 100%, just like everything else. What is the only 100% viable form of contraception?
Not having
Not having sexual intercourse.
Not having the intercourse. Okay. What is it called when the uterus is going back to its regular pre-pregnancy state?
Involution.
Involution. Ow. Okay. So we've got involution, and if it doesn't return, what's it called?
Subinvolution.
Subinvolution is it does not return completely. Now we've got healing of the placental site, which is a process of exfoliation to prevent leaving a fibrous scar. Now, why does it take time? Why doesn't it just kind of quickly heal up?
Repeat that?
Why don't we just quickly heal up that placental site? Why do we take so long to actually fully heal up that placental site?
What are we on? I'm sorry, the phone was ringing.
Why do we take so long and use exfoliation to allow healing of the placental site, and why doesn't it just heal up right away?
What are we talking about, though?
It was
Placental site, where it was.
in the uterus. So the process of it exfoliating inside the uterus in order not to leave a scar from the placenta being there.
Yes, exactly. We're going to take its time so we don't have the scar. If you have a scar, guess what that increases your risk of happening?
Uterine rupture?
Uterine rupture is one.
Infection?
Infection could be, yeah. Ectopics. Improper implantation. PIA or AIP. Depending on which way we're looking at it. All right. Menstruation and ovulation. If a woman is not lactating, she'll be back to menstruation around when?
3 or more months.
6 to 8 weeks.
6 to 8 weeks.
6 weeks.
Yep. The
Uh-oh.
first cycle may be anovulatory with no ovulation, but it could still be with ovulation, right?
Mhm.
How often, what's the ideal wait time between pregnancies?
A year.
1 year. And now if you're a lactating woman, what will that do to your ovulation?
It may delay it.
Yeah. 3 or more months. Yeah.
They can delay it longer. Yep, delay ovulation and menstruation. We need to educate. Ovulation can precede menstruation, so they can be ready to go for pregnancy before they realize that they're ovulating. So they're going to need contraception for that time period.
The mini pill.
The mini pill or the Bar, rar, 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 rar. See, she agreed with the mini pill. All right, GI system. What's going to happen to our GI system postpartum?
Gaseous.
We want gaseous.
Yeah.
It's going to
Lettuce.
decrease.
We have lower GI motility. It's still going, right? It's still that, got to get moving again.
Relaxin.
That's still rolling. We have decreased muscle tone in the abdominal wall, right? We have stool softeners, such as
Colace.
Doclax.
Kool-Aid.
a little slow on that one, Jamie.
I know.
We can also do what to help with the constipation issues?
Fiber.
Water.
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 Exercise.
Move them around, get them moving.
You got it, girl.
What is it called when our muscles pull apart here during pregnancy?
Rectus diastasis.
Diastasis recti. Laxity of the pelvic joints and ligaments are caused by what hormone?
Relaxing.
Relaxin. Of course, that increases our risk of injury as well, right? So we need to keep that. Don't lift anything more than what the baby weighs for a while. It relaxes our soft tissues, causes muscle fatigue, body aches, separation of her abdominal wall. We need to make sure she has a correct posture and does her modified sit-ups. What other tool could she use to feel more comfortable to keep everything in?
Support. She
Oh,
can
support
put her hands
belts.
and
Yes.
Yeah.
Yep, abdominal binders. Culture sensitivity. We need to make sure we do our cultural assessments, expand knowledge and understanding, culture and influence beliefs, common health care practices, customs and rituals. Postpartum. What's unique about the Indian culture?
the 40-day confinement period.
Uh-huh.
They don't have to do house chores. They don't have to cook. It's just special time with bonding with the baby. So other women in the family will come and help with those things.
Yep. They cook, they clean, they don't wash their hair
Why?
because washing the hair would more than likely be cold water, hot, cold. And their body's cold. We want everything to be hot. They will not eat sour foods either.
Right, only spicy.
Spicy, we want everything warm or hot. No cold ice, chips, anything like that. Hot to drinks, pepper, garlic. No ice, cold temperatures or decreased temperature. Blankets, warm up. They're probably not going to wash their hair for that 40-day period. Use warm temperatures. Okay. Activity and rest. Do we want mom walking around early?
Yes.
Yeah.
Yeah. Still watch out for that whole dizziness, fatigue, that numbness and tingling. Let her take her time for that. But we want her moving as soon as possible. Help with that peristalsis, right? What's there some mild exercises she can do even while laying down?
Kegels.
Kegels?
Yay, Kegels.
How do we explain to her how to do that?
Like holding your pee.
Yes, try to stop urinating. Increase your vaginal tone. Increase this exercise gradually. Take frequent rest periods and adequate sleep. When the baby's asleep, you should be sleeping. No heavy lifting. And while you're here, if you need to take a nap, it's not a bad thing to say, hey, I need help. Would you mind watching the baby while I take a nap? Or dad can take over, right? If he's there. Nourishment. So, way back when, how much weight should you gain during pregnancy?
25 to 35 pounds.
First trimester.
First trimester's 5? Yeah.
3 to 5 pounds. Right? And then after that, it's 1 pound per week until birth. So weight loss now. 10 to 12 pounds right at birth. So you got rid of the first trimester and some. Right at birth. The next week, 5 more pounds. So through the baby, so due to the passenger and the fluids, you've dropped 10 to 12 pounds right there. And then about a week later, thanks to diaphoresis, you lose 5 more pounds. Appetite is going to come. Your balanced diet needs to be kept up. Your multivitamin supplements. And if your hemoglobin's low, what supplement would be important?
Iron.
Iron. What kind of food would you want to give?
Spinach.
Green leafies,
Red
meat, burger,
Cheeseburger.
Livers.
cheeseburger. What's important about that cheese?
Calcium.
All right.
What about if you're breastfeeding?
What about if you're breastfeeding?
You need to increase your calorie intake.
Yes,
By
by about
500.
5. But what will that also help you do?
Lose
Burn
weight.
calories.
Burn your calories up. Yep. Breastfeeding, how long? And if you're going to have breastfeeding for longer than a year, it'll help increase that weight loss. You should be voiding how often?
Every 4 to 6 hours.
Yep. Monitor your eyes and nose daily. Look for normal diuresis because, you know, within that first day you're looking at 3,000 milliliters. Get rid of all that IV fluid, etc. Increased risks of infection otherwise. Urinary retention can occur. Constipation can occur. And we already talked about medication to help with that, right? Stool softeners. Why are moms worried about that?
Episiotomy, tearing
Episiotomy.
lacerations.
And
It may hurt.
And hemorrhoids.
Hemorrhoids, they don't want to push.
Perineal care. What's up with that perineum?
It is.
It's acceptable to infection.
Yep, we got lots of issues. Risk of infection. We need to educate them on that because they're probably going to need a mirror or somebody to, the same person to look at it. The same person look at it. Look for discharge, increase in swelling, redness. Remember Rita. What is it?
Oh, redness, edema, ecchymosis, discharge.
Approximation.
Yep.
Thank you. I can never remember that word.
It's a hard word to remember.
But yeah, there's your Rita right there. If there, of course, is that necessity for the approximation, more than likely. Teach perineal hygiene, hand washing. How long would you not want to put tampons in?
At least 6 weeks until the doctor releases you.
Yep, for at least
If they
6
don't want to
weeks.
have sex, you don't want to put anything in there that could.
No vaginal intercourse.
Right.
Well, I'd say no real insertion for a while. Cesarean births. Who's giving perineal care until they can ambulate?
The nurse.
The nurses, right. What would happen if you start, you know, you put a tampon in, you start having sex too early, you start douching?
You can damage the inside of your uterus.
Well, you're looking more for something you could damage it. Let's think of something a little more risk of.
Infection.
Risk of infection, endometritis. All right, what do ice packs do?
Decreases inflammation.
Decreases edema and pain.
Mm-hmm.
Vasoconstriction, numbing for your pain. Do we just keep it on?
No. 20 minutes on, 20 minutes off.
Yeah. Apply for 20 minutes every 2 to 4 hours for the first day. Alternate with warm, moist heat when you go home. Heat, hot, cold, hot, cold. Afterbirth pain occurs during when?
After birth.
What's that terminology?
The fourth.
Involution.
Oh, involution.
Afterbirth pain is the intermittent uterine contractions during involution. Everything's trying to get back. That pain is because of everything's trying to get back to normal. It's those random contractions. What would cause these to become stronger?
Breastfeeding.
Breastfeeding. Yep. Releases what hormone?
Oxytocin.
Mm-hmm. Duration, 2 to 3 days, usually for afterbirth pain, mild analgesics. What are some mild analgesics for the afterbirth pain? Just for vaginal.
Ibuprofen.
Ibuprofen. That's a good one, right? What else?
Tylenol.
We got lots of little ones for the moderate or mild to moderate. We've got our ibuprofen, Motrin, we said. And actually, I think that's all the ones we had to really know. Okay. There are other ones, but those are the ones. Oh, ibuprofen, Motrin, you got it already. Okay. Now, let's say they want a tubal ligation, postpartum surgical patient. Why would they vote to do this now, of all times?
They'll already have their epidural in, or they can do it during the cesarean.
Mm-hmm. What do we need to educate them on right after birth if they're going to do this? NPO.
NPO. Okay.
NPO.
Well, they're not normally eating.
Right, yeah, for that point, but they need to be NPO post-delivery. Cesarean birth. They're going to be hungry, though.
Yeah,
Cesarean
they'll be
birth.
starving.
Incisional wounds. Before we discharge them, they probably had, staples or sutures there. What do we need to put there for them?
Well, after the staples are removed, they put the Steri strips. Right?
Steri strips, yep. And again, same person needs to view the incision daily, see if there's a difference. When they come back from anesthesia, it's the same thing as PACU. Always watch our airway. They're not going to send it to them necessarily, but watch your respiratory patterns, educate the patients. Respiratory care 1 to 2 hours post-op, and get on oxygen. Breastfeeding choices. So,
Feeding choices or breastfeeding choices?
well, excuse me, feeding choices. We know what the bottle does. Bottle gives it easier access. Lots of the stuff that we know what's inside of it, right? We know what's inside of it, easier to measure. But why would we want to breastfeed?
They get antibodies from the mother.
Yeah, let's start with the baby. Immunity, maternal antibodies. What else?
Bonding.
Bonding. It's always good, especially that first hour.
There's less chances for childhood obesity.
Yup.
There's also less risk for some certain childhood cancers. There's some other stuff.
Boob versus bottle fight. Baby. You already said most of these, but immunity, maternal antibodies, and protection from some cancers. Increased GI maturation, decreased chance of diabetes mellitus type 1, decreased chance of childhood obesity, and increased jaw development. And for mama, decreased risk of breast cancer, amenorrhea due to lactation, enhanced involution, weight drop, increased bone density, and bonding, as you've already said.
It's cheap.
And it's cheap, and it helps you lose weight. Okay. Let's see, we've gone through that. If we can't get them to latch, can we still give them breast milk?
Yes.
Yes.
Pump
Pump
it.
it. No matter what the choice, though, what do we make sure we never do? Sherry, what do we never do? What do we never do to a patient?
Oh, we never force her to breastfeed.
Yeah, we never judge their decision.
Yeah.
I know you like to judge on your questions.
Just that one.
Just that, 3 that we've done. Okay, physiology of lactation. What is giving the breast its shape?
All of those ligament things.
Sherry, Sherry.
What do you mean what it's giving its shape?
Jamie, I can see Jamie knows. Cooper's ligament.
I was going to say I have Cooper's ligament, but...
That's it. That's the thing that gives the breast its shape. Do you need to see a picture of that?
No, I need to read it in the book so I can get it in my head.
Let's see a picture.
Okay.
So when you see the picture, it helps make sense why it gives.
Is it the picture that was in the book?
Do I ever give you the picture in the book?
No.
On occasion.
No, on occasion.
I found it. Hey. Cooper's ligament, along with the fatty adipose, give shape and support.
Yep. There it is. And sharing now. There's your Cooper's ligament. As you can see, it's actually, these are part of the ligaments. It's holding up the tissue. Okay?
Gotcha.
So now that you've seen that, now that you've seen that picture, you should know the answer to the rest of this stuff. What is the breast structure mostly made of? When you're not pregnant.
The milk ducts? Oh, when you're not pregnant. Sorry, adipose tissue?
Adipose. Then you get pregnant, your tissues get activated, you get your lobulars, and you get your ducts, right? Your alveoli.
Mm-hmm.
So, the same idea kind of as your kidneys in there. Let's go back to it. Same idea kind of as your kidneys you can see in there. You get all these little alveoli, and they kind of all pool together in one duct, and out they go.
Engorge.
And the big old boobies. Now, lactogenesis, what's that?
It's the process of the milk secretion.
Creation. Genesis, creation.
Colostrum.
Yeah, colostrum. Jamie's like, I'm going to say something before it barks. So yeah, we've got prolactin and oxytocin being released. Around 26 weeks, this will start to delivery. Colostrum's being made. Baby needs this colostrum until the milk starts. This usually has your white blood cells and immunities as well. Milk ejection reflex is also known as your letdown. If the mom can't feel it letting down, is that a bad thing?
No.
No. It doesn't mean the baby's not getting food either. What is it supposed to feel like?
Pins and needles.
Pins and needles. Yep. More than like, what's one sign that the baby's getting enough food?
Weight
Weight
gain.
gain.
Weight gain. That takes time, though. What about after that? Right after pregnancy, right after feeding. Sleepy. They could go to sleep afterwards if they get enough food. Okay. If they're not breastfeeding, what can we do to help decrease the breast size?
Cold.
Ice packs.
Hmm.
And what's an issue with ice packs in certain cultures?
Some cultures look at cold being as unhealthy.
Mm-hmm. If we're not going to use an ice pack, we could use cold cabbage leaves, but same problem. And there's no longer a medication that we like to use for that. We want to initiate breastfeeding within how long of birth?
Within an hour.
1 hour.
Why? And the baby's more alert and active at that point. We want proper latch on, which means the baby's taking in what?
The milk.
The areola.
And the nipple. Right. Well, it does. He's taking in the milk, yes. If he only takes the nipple in, what's more likely to happen?
Pain
Pain.
will occur. Baby may not get.
Baby's not getting the milk.
Yeah, they're getting a lot less milk. It's still going to get milk. The breast itself is going to have trauma and pain, so it's going to start making
harder. It's going to chafe. It's going to crack. It's going to hurt.
There's our bubble he right there, right?
Mm-hmm.
Assess for milk letdown. Assume a position of comfort. Assess for infant weight gain. Wet diaper count. Make sure the baby's, actually going. Some ineffective if ineffective breastfeeding can occur, we've got incorrect latch on due to nipple trauma stuff. Our breast engorgement. If we can't get it out of us, and you are breastfeeding, but you need to get some of that relief out, but the baby's not there, how do we help?
The pump.
What if you don't have a pump?
Can't you manually express it?
Manually express it. Just get it out. We also have our cultural considerations with that as well. Collecting and storing breast milk. What is the best pump? Type of pump.
Best?
The breast. What is supposedly the best type of pump to use?
A dual
Electric.
pump?
The electric double. Well, both. Not one at a time. But you can use single hand pump, etc. But they're saying that the best one is the electric double. Storage of your breast milk. Fresh is best, but
You can freeze it.
you can freeze it. How long?
Isn't it in the months?
6 to 12 months. Refrigerate it. How long?
24 hours?
5 to 7 days.
Oh, well, that's
Back in the
that's
fridge.
engorgement. Never mind.
Yeah, we're talking about that's important. Yeah. And your Fresh Express, as long as it's not in a warm room, looks like it could be there for about 4 hours. Warm room, 1 hour. All right, bonding time. We want this as the transition to parenthood. They're going to assume the mothering role, paternal bonding time and factors, and then of course our factors that interrupt bonding. So, Rubin's phases of mother assuming the role. What's our first phase? It's in the first 1 to 2 days. It's kind of like nursing school, if you think about it.
Into or something?
Taking in.
Taking in. I said into.
Yeah. Taking in. Recover from exhaustion. Depend on others. You have exhaustion. You're excited and confused. And you have verbal mental reliving. You have verbal and mental reliving of the labor. Again, nursing exam. 2, taking hold. This is day 2 to 3. Initiate or not of care. You need help with care for the baby, and you're anxious about your skills of being a mother. Is there enough money? Oh, excuse me. And then part 3 is between 2 and 6 weeks. So the first one is taking in 1 to 2 days, taking hold 2 to 3 days, and then letting go 2 to 6 weeks. Redefine your role. You see the baby as an individual, and you focus more on the world, the partner, sharing, family. Factors that interrupt the bonding process would be what?
Finances.
Finances.
Stress. Housing.
Housing. Car.
Transportation.
Right. What was that?
Transportation.
Transportation, yeah. Type of relationships at home. Okay, what is the purpurium?
Time after birth.
How long?
3 months?
6
Birth
weeks.
to 6 weeks.
Birth to
After
6
birth to 6 weeks.
Yes, after birth to 6 weeks. First, let's see, during the purpurium, which is the first 3 months, is the most vulnerable period. We have our baby blues.
Which are normal.
Normal, you have your hormones resetting. Of course, it's going to be off. Postpartum depression. That's that guilt, fatigue, you feel worthless. Talk to your doctor. Might be something they can do about it. When is it a problem? Like, oh my gosh, something bad is going on.
When they want to hurt themselves or the baby.
Or someone else, yeah. That's called what?
Postpartum psychosis.
Psychosis. Yep, that's very rare. Delusions, agitation, sleeplessness, self or baby harm thoughts, seek help. History of mood disorders gives you a high risk of your postpartum psychosis. Physiological response at this point is your tiredness and fatigue. This is normal. So, discharging plan and teaching, we've talked about fundus, we've talked about lochia, which are what colors would be first 3 days?
Rubia.
Rubra, which is what color?
Red.
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 And then 4 to 10 days?
Cirrhosis. Brownish.
Brown, pink, depending on what we're eating, but brownish pink, yeah. And then
Alba.
10 to 14, alba or white, that would be our leukocytes. And those can technically last for weeks beyond that, but that's our alba. Normally only seen 10 to 14 days. We've talked about hygiene, incision, temperature. What temperature above, what temperature are we watching for?
100.4.
100.4, we're worried about infection. Elimination patterns, rest, pain, perspiration is normal during that first day or so, a large amount of it. We have to let them know that. Weight loss, exercise, nutrition, mood, sexual activity, and contraception. When should they start taking their pills again?
What kind of pills?
The pill.
Birth control, 6 weeks.
Yep. Their postpartum visit. Before that, use condoms. Anything else? Done. What are some special need populations?
Adolescents.
Adolescents, right? Do they have support? Do they need resources? Do they need community assistance? What about adoption babies?
Mm-hmm.
Do they want to see the baby? Does mom want to see the baby? Is the adoptive family ready or present? And remember, mom can do this as soon as labor is done. Older mothers, what's the issue with older mothers?
More anxious.
They've done their research. They've waited. They know things have happened. Or I'd say nursing students who just finished OB.
Right. And genetic testing, genetic.
Do they have an amniocentesis? Especially if they're over 35. We need to reassure the patients. Community resources, support groups, home visits, telephone follow-up, usually from labor and delivery. Outpatient clinics. Now, why would we choose to go to an outpatient clinic over an OB?
finances. They may not have insurance.
Well, how did they get to go to that OB before then?
They may not have, right?
Medicaid and pregnancy.
Oh.
Tennessee, and I think it's most of the states, if not all of them, if you're pregnant, you get on Medicaid if you don't have anything. But once you're postpartum, it's gone. The baby gets to go on it. So that's the idea of the outpatient clinics. Why would they have L&D phone calls for follow-up?
To check on them, see how they're doing.
Mm-hmm. Also to recognize a good nurse, a good doctor, their experiences if they have any complaints.
Mm-hmm.
Postpartum hemorrhage, we need to accurately estimate the blood loss within the first 24 hours versus late, which is within the first 6 weeks. We have Larry, which is about our lacerations, atony, retained placenta, ruptured uterus, or you pulled too hard on the cord, which leads to what?
Uterine inversion.
Yep. And there are 4 T's: tone, trauma, tissue, and thrombin. What can we do to help measure this hemorrhaging?
Weigh the pads, weigh the sheets if they've hemorrhaged on the bed.
Mm-hmm. And help volume replace. So we had our abnormal adherence, right? Remember that?
Mm-hmm.
Acrita, incrita, percrita. AIP. Right?
Yes.
All in the placenta. So, acrita is just slightly into the myometrium. Incrita goes deeper into the myometrium, and percrita is through. Which one requires a loss of the uterus and D&C more than likely?
Procreta.
Percrita, as well as incrita, may require that, depending on how far it does get in there. But it's the whole idea of invasion of the myometrium.
No.
Postpartum hemorrhage, number 1 cause.
Uterine acne.
Uterine atony. Yep, not acne. What's our hallmark of uterine atony?
Boggy.
Boggy, soft uterus with clots and blood. Genital tract trauma. The uterus can be firm through involution process. We want that. Tissue, thrombin. Let's see. Postpartum hemorrhage. Late postpartum hemorrhages, we still always have our risk for infection. You can have those retained placental fragments of cotyledones, cotyledones, whatever we say them. We want to decrease or increase our uterine tone. What are some medications we can give to help with that?
Pitocin. Right? Because you want
Pitocin is a
to
good one.
contract.
Mm-hmm. We have one more medication that we have on our list to know that causes contractions.
No. That causes contractions? Don't they need an antibiotic?
This one's interesting because it's a combination thing here, but it's we've got 2 more. I'm sorry. We've got oxytocin, hemabate, and Cytotec. Cytotec is that prostaglandin, remember, Misprazole, which can cause everything to open up, but it will also be a contraction stimulator. So we've got 4 total ones. Pitocin, oxytocin, Methergin, Carbaprost or Hemabate, and Cytotec. Sharing our screen, because we all love our screen. Remember these now? Pitocin, Methergin, Carboprost, or excuse me, Hemabate, Cytotec. These can all, Cytotec is more of the prostaglandin, so we go over everything up, but it's also a contraction stimulator. What color should be contraction stimulator? What color do we like for contractions?
Red.
Ooh, red, brown. Make them pain. Make them pain. Okay. All right. So we've done that. So don't forget about our postpartum hemorrhage. Back to it really quickly, though. We're accurately estimating blood loss. We have to have our early, which is the first 24 hours, versus late, which is up to 6 weeks. We have Larry for that, lacerations, atony, retained placenta, ruptured uterus, or you pulled too hard for reasons that you'd have hemorrhage. Your tone trauma, tissue, and thrombin. Let's see, postpartum hemorrhage as well. We can have late postpartum hemorrhage, retained placental fragments, medication to increase the uterine tone. Again, we said Pitocin, Methergin, Carboprost or Hemabate, and Cytotec. If we hemorrhage too long, what could we lead into?
Shock.
Yes. What type of shock?
Hypovolemic.
Hypovolemic shock. You got it. Now, if we have all this stuff left inside, whether it be placental fragments, etc., probably what we're going to have to do is what?
DNC.
DNC. Let's see. We've talked about these before. Collaborative management, frequent vitals, fundal massage. We have to note the patient's behavior. If they're talking to us, everything's going good, and all of a sudden they lose consciousness, what's that a sign of?
Not enough oxygen, so no hypoxic baby.
Well, this is postpartum.
Oh, we already have the baby?
The babies, they already have the baby. Hemorrhage.
Oh, hemorrhage.
Yeah, it's like everything's good, and all of a sudden they've just lost so much fluid, they're out. Medical management depends on the cause. Administer oxygen. Check the labs of a CBC for baseline and get follow-ups after the treatment. If there's atony, we want to give Pitocin. If there's adherence, DNC. If there's DIC, which is what?
Coagulation issue.
That's one letter.
Curettage?
Oh, no, DIC. DIC.
Oh, Dick.
Disseminated intravascular coagulopathy. How do we treat Dick?
You give them platelets.
Fresh frozen platelets. And if it's uterine bleeding, put a balloon in it. There's a balloon in the uterus to hold it up, right? So our causes for collaborative management: atony, Pitocin, get it contracting again, or at least get our medications in there that can do that. We have oxytocin, we have our methylagovin, our Hemabate, Cytotec, depending on what we're doing. Although we probably don't want to do Cytotec on that one. Adherence, DNC, Dick, fresh frozen platelets, uterine bleeding, balloon in the uterus. Let's see. If there's hemorrhaging, if we start seeing hemorrhaging, what do we need to have available on mom?
Blood.
On mom. We're not going to have a bag of blood sitting on mom. What would we have in one of her arms?
Oh, an IV, large
IV
cordial.
access is necessary if hemorrhaging is occurring. Remember, with our medications also, if she's no longer pregnant, we can do higher doses. So if we're using Pitocin to contract, we get a higher dose at that point. Let's see, Pitocin, we'll be, diluting that in 500 or 1,000 milliliters of fluid. Then we have our Methergin. If it's not working, we can go to Hemabate. What's the problem with Hemabate? When would we not give Hemabate?
Asthma or glaucoma.
Also, it causes diarrhea. So if they've had an epidural, they've had Hemabate, and fundal massage, incontinent diarrhea. Remember that?
Mm-hmm.
So, the other thing about Hemabate is it's extremely expensive. And it's in glass vials. With the Cytotec, we're going to have to monitor that uterine response via palpation. We're probably going to be sticking 4 tablets in rectally, but no KY jelly. We'll use water as lube. All right, hematoma, what's that?
Blood underneath the skin.
Blood underneath the skin. Can it be inside the vagina?
Yes.
Yeah, so you may not be able to see it. They're going to be feeling that pain, though, aren't they? Yeah, they're going to be feeling that pain. It's localized collection of blood and connective soft tissue under the skin without injury to overlying skin. We'll use ice narcotics. Unremitting pressure and pain. Collaborative management would be careful assessment and implement pain relief, because if it gets too bad, they'd have to drain it. Puerperal infections, what's that?
Just postpartum infections.
Like
Endometriitis.
endometriitis, which is the uterine lining, right? What else?
Mastitis, the breast,
Yep.
and have an infection. Any operative wound, like if they had a cesarean, episiotomy,
Yep.
and UTI.
Yeah, UTIs. Okay, so endometriitis, uterine lining. If we have an infection in the uterus, it's in the abdomen, so what do you expect to feel? Anything that's bothering you in the uterus, or anything in your abdomen, what's what you're probably going to feel there?
Pain.
Pain, cramping. And it's an infection, so you'll probably see purulent lochia. We've also got mastitis, swollen, red, hot, flu-like symptoms can occur. You can also see your purulent at that point. Operative wounds, C-section, episiotomies, Rita. Rita, what is Rita?
I answered that last time. Somebody else has to answer it.
Monica's too quiet. Monica, Rita.
Redness, edema, ecchymosis. A is not a combination. When you put the fishes need to be close together, touching each other. Approximation, that's right. And then D, I can't remember what D is.
Drainage.
Drainage.
Drainage. Okay.
Yes, your drainage. So again, it's just the same stuff is coming up over and over again. It's just in different ways. We know how to look at this stuff. Just realize we're going to be using the same skills over and over again to look at these things. We have an incision. We're going to look at the incision the same way. This is what we're looking for. Looking for signs and symptoms of infection. Looking for signs that this is actually staying closed. Making sure that this is actually healing and going down and swelling, not going up. UTI, polyuria, pyuria, careful assessment of fever, abdominal cramping, purulent lochia. If we have endometriitis, what are we probably going to have to give them in the hospital?
IV antibiotics.
IV antibiotics, because it's an internal infection. We got to take care of that. We're going to need them to rest, increase their fluids, give them proper nutrition, comfort measures, NSAIDs for pain and fever, and educate the patient on family and what happened, and what else we can do to help with that. Thrombophlebitis and thrombosis, inflammation of venous circulation and blood clot formation. So we have high volume, high stasis, and hypercoagulability state, even at this point, because it takes a while for us to drop all those clotting factors to normal. So, pathophys, hypercoagulable, venous stasis, and vein injury. Signs and symptoms.
Pain.
Of pain. There's a DVT or anything down there. What are you expecting?
Pain, tenderness.
Red, swollen.
Or
They may be asymptomatic. There may not be any signs.
right, it may be asymptomatic. It may just be sitting down there and then it just could dislodge. Those are the dangerous ones. How do we diagnose a DVT?
Doppler.
Yep.
MRIs.
And how do we diagnose a PE? MRI. But we also could use a VQ scan. Remember that? Okay. Collaborative management for all this, analgesics. Elevate the extremity TED hose, increase fluids, apply moist, warm packs, bed rests. Again, we've talked about all of this stuff. Anticoagulation treatments like Love Knox. Measure leg circumference, make sure it's not getting bigger. What are our signs of a pulmonary embolism occurring?
Chest pain.
Sudden, abrupt,
Sudden, yeah.
and I need the correct term for chest pain.
The correct term for chest pain. Anyone? Jamie doesn't know.
Angina pectoris.
You know? Wow.
Angina pectoris.
Apparently John knows.
So yeah, we've got angina pectoris, dyspnea, diaphoresis, syncope, and anxiety. Why would we have anxiety with a PE?
Impending doom.
Yes, the impending doom. All of a sudden, we're not getting oxygen. Diaphoresis, freaking out. Dyspnea, again, it's difficult to breathe. Syncope, fainting. And our angina pectoris, or chest pain. ABC response, even though it's CAB. Limit your visitors, educate the woman and family regarding prevention of thrombus. How do we prevent this? What do we put on them?
TED hose.
TED hose, SCDs, prevent venous stasis, sequential compression, TED hose. We can also use our anticoagulation treatments. All right, we've talked about all these other ones.
I kind of said that.
Postpartum psychosis we've talked about. Postpartum psychosis, does that require hospitalization?
Yeah.
Yeah.
Yes, it's not the blues. Postpartum depression, they can exist for most of the day. ID your risk factors, screen them at postpartum visits. They need medication or some therapy. Support bonding, psychosocial. Encourage rest, teach them to seek help if they're overwhelmed, perform holistic assessments, and advocate for home follow-ups. All right. We've now gone through all this stuff. So, I'm going to name a drug. You're going to tell me what it does. You ready?
Sure.
All right, here we go. Docusat sodium. Coles.
Oh, for constipation?
Yep. Dose is 50 to 500 milligrams PO. It's a stool softener. Bisacodyl, Doculax.
That's also a stool softener.
Stool softener, 10 to 30 milligrams PO. What is the issue with taking any of these stool
They
softeners?
get addicted to them and depend on them.
Dependence. Not so much addicted, I'd say dependent. But yeah, it's the same idea.
Okay, dependent, sorry.
Yeah, because otherwise the body's going to get used to the fact that they're constantly taking this and doing it for
If
them.
they're dependent on it, wouldn't that be the same thing as addicted?
Addiction.
No, addiction
Causes.
and addiction is the body like you absolutely have to have it. You're going to go through withdrawals type thing, but we'll go into that. But just the idea of we have to have it, otherwise the body's going to have a hard time getting us back and going because our body gets used to us having it and doing the work for it. Let's see, witch hazel, Tux pads,
Pain.
hemorrhoids, incision care, topical. Yeah, pain can help with the pain. Lidocaine spray,
For pain.
pain and an anesthetic. Motrin, ibuprofen,
Inflammation.
anti-inflammatory, mild to moderate pain. How much do we give?
400 to 600?
400 and over 4 to 6. Yeah, 400 milligrams is what we have on here. Darvocet.
Is that a opioid?
Opioid and acetaminophen. Moderate to because we said automatically opioid, we think moderate to severe pain. 1 tab, PO, Q4. What do we watch when we're giving these? What do we have to educate them on when we're giving a Darvocet?
How much acetaminophen they're taking in?
Yes, they can't exceed what number?
4 grams?
They cannot exceed 4 grams a day. Percocet.
It's also an opioid for pain.
Oxy and acetaminophen. Yep. Moderate to severe again. Opioid, 1 to 2 tabs every 4 to 6 hours. And again, watch the acetaminophen levels. Hemabate.
What was it?
Hemabate.
It's the contractions. It stimulates.
Yeah.
Yes, carboprost is the other name for it. Contraction stimulator. 250 micrograms IM or intrauterine. Do not give for asthma or glaucoma and can cause diarrhea. Rogaine.
It's the RH.
Negative. Mom.
RH negative mom.
Who has and if it's an RH positive baby.
How many doses would you give if mommy was RH negative, baby was RH positive, and she had no antibodies?
2.
Breathe in, brethren.
It's a totalytic.
Tocolytic, yep. We give this for preterm labor, placenta previa, incompetent cervix, maybe for PROM, 48 hours or so. What is the antidote to mag sulfate?
Calcium gluconate.
How often do you give it, and how much do you give?
I don't remember.
You give 10. No.
Oh, right. It was 10 to 40 when you're infusing it, but if it's a one-time shot, it's just 10.
10, how quickly?
1 to 3 minutes.
1 to 3 minutes until signs and symptoms are gone. Procardia.
That's a tocolytic.
Same idea. Also, what else is procardia for? Pregnancy.
Hypertension.
What type of hypertension?
Preeclampsia.
Yes, chronic and acute
Oh.
hypertension, but you have the same idea. If you have chronic, we have to, of course, watch our skin reactions, mag sulfate reactions, because if you're having a mag sulfate reaction, you're not going to give Procardia. 10 to 30 milligrams PO. If it's a chronic hypertensive medication, it's PO for pregnancy. If it's an acute, it's either going to be a bolus or some sort of weird one, like a PO maybe, or another bolus. But the idea is get it in, get it taken, the little problem taken care of now. So, alpha methyl-dopa.
Chronic.
Chronic hypertension. Alpha adrenergic inhibitor. Watch for liver dysfunction and a positive Coombs test. What's positive Coombs?
It's where mom is O blood type and baby's AB, and they do that Coombs test, and if it comes back positive, we have to watch for jaundice.
Mm-hmm. So you wouldn't give that alpha methyl-dopa if they have a positive Coombs test. Let's see. Labetalol.
It's a beta blocker for hypertension.
Chronic hypertension. Do not. So if it's a lull, when do we not give it?
When they're bradycardia.
Bradycardic, asthma, heart block, furosemide.
Lasix, loop diuretic.
When?
Hypertension.
What type?
Chronic.
Chronic hypertension. So PO, 20 to 80. Wouldn't give this with. When would we not give furosemide?
If they're hypotension?
Well, yeah, if they're hypertensive, you're not going to want to give a hypertensive. If they're hypotensive, don't give them a hypertensive medication. If they're not peeing, anuria.
Oh.
Anuria, dizziness, gout. Sodium nitroprusside. Don't let this one kick you in the butt.
Is this a diuretic as well?
No. Listen to the name of the thing. Sodium nitroprusside.
How do you say it? Vasodilator.
It's a nitro. You got it. It's a dilator. We want everything. It's nitro. Again, acute hypertension, vasodilator. This is the special one, though. 0.25 mics per kilo per minute, titrated again to 0.25 mics per kilo per minute every 5 minutes until you reach your max of 5. Diamond hydronate.
Dramamine?
Dramamine. Yep. What's that for?
Nausea, vomiting, hyperemesis gravidarum.
Yep. Oh, I forgot to totally fill these in. Antiemetics. Yep. So let's see. Dilaudid.
We can give Dilaudid and Demerol for sedation. Is that right?
Yeah, it's also remember, Dilaudid is a opioid. but it also can be used, for the sedation aspect of it. Anxiety and pain for Dilaudid Demerol. If the respirations are above 12, we can give that.
Is that the one that you give when they have the rapid delivery?
I believe so. Yes.
For
Precipitate labor.
specific labor, yeah.
Let's double check that real quick. Precipitate labor. I don't have those down for precipitate labor.
I think it's for hypertonic dysfunctional labor pattern.
There it is. Hypertonic.
Okay.
Dilaudid and Demerol. Hydration. Yeah, because it's going too fast for hyperstimulated. Calm them down. All right, let's see. We've done all of that. So you guys did pretty well on that. We'll jump around some more in a little bit, but all right. We've got 30 minutes. You want to do questions?
Sure.
All right. Let me grab these. All right, moving into questions. Let's take well, we're all recording. Let's take 5 minutes while I set this up. How's that?
Sounds good.
Bathroom, etc. That way, people who are listening can take 5 minutes to like do. Yay. Okay. And the people actually paying attention. People actually want Thursday's lecture. Oh, okay. You ready for questions for the last 20 minutes?
Sure.
All right, moving into it. We left off on the high-risk intrapartum, so that's what we're going to pick back up. And we're going to jump forward a bit, just a little bit. So, let's do this. A woman has received Prepidil, a dinoprostone gel for labor induction. The nurse should be prepared to administer the medication via which of the following routes: intravenously, orally, endocervically, or intrathecally.
Number 3.
I agree.
3.
Yay! Yep. A woman, 40 and 2 7-week gestation, has ruptured her membranes for 15 hours with no labor contractions. Oh, that's right. We don't care about this one. The nurse turns off the oxytocin infusion after a period of hyperstimulation. Which of the following outcomes indicates the nurse's action was effective? Intensity moderate. Frequency every 3 minutes. Duration when flexed.
Number 2.
Yep. Frequency every 3 minutes. And of course, duration. We don't want 2 minutes of contractions. A nurse is monitoring the labor of a client who's receiving IV oxytocin pitocin at 6 milliliters per hour. Which of the following clinical signs would lead the nurse to stop the infusion? Change in maternal pulse from 76 to 98. Change in fetal heart from 128 to 102. Maternal blood pressure of 150 over 100, or maternal temperature of 102.4.
2.
2. Yep, dropping below what we need it to be. Prima Glavid client receives Prepidil for induction 8 hours ago. The Bishop score is now 10. Which of the following actions by the nurse is appropriate? Perform nitrazine analysis of amniotic fluid. Report abnormal findings to the obstetrician. Place woman on her side. Monitor for onset of labor.
Monitor for onset of labor?
Or
Yes, monitor for the onset of labor. The physician has ordered Prepidil for 4 gravidas at term. The nurse should question the order for which of the women? Prima gravida with Bishop score 4, multigravida with late D cells, G1 P0 contracting every 20 minutes by 30 seconds, G6 P3202 with blood pressure 140 over 90 and pulse of 92.
2.
Yes, that's fetal distress. Induction is contraindicated with that because it could cause injury. A client, G4P1021, has been admitted to the labor and delivery suite for induction of labor. The following assessment has been made. Bishop score of 3, Fetal heart rate of 156 with good variability and no decelerations. Temperature is 98.6, pulse of 98, respiratory of 20, and blood pressure of 128/80 with negative obstetric history. Cervidil has been inserted. Which of the following findings would warrant the removal of the prostaglandin suppository? Bishop score of 10, fetal heart rate of 152, respiratory rate of 24, contraction frequency of 1 minute.
One.
Four.
Four.
4.
As she's starting active labor.
Yeah. 10, she's ready.
And let's see. And what 4 would mean hyperstimulation. This frequency is the beginning of one to the beginning of the next. How long should you have, at least? You know, even in active transitional phase.
Transitional phase could be like 90 seconds, can it?
Yes, 90 seconds is longer than a minute.
Mm-hmm.
Yeah.
Still gives you a good 30 seconds. There are
Or the
4 clients.
frequency. Okay.
Yes. There are 4 clients in active labor in the labor suite. Which of the women should the nurse monitor carefully for the potential of uterine rupture? Age 15, G3P0020 in active labor. Age 22, G1P0 eclampsia. And age 25, G4P3003 last delivery by cesarean. Age 32, first baby died during delivery.
Delivery by cesarean gives the highest risk for uterine rupture.
Yep. The client is admitted in labor with spontaneous rupture of membranes 24 hours earlier. The fluid is clear and the fetal heart rate is 124 with moderate variability. Which assessment is most important for the nurse to make at this time? Contraction frequency and duration, maternal temperature, cervical dilation and effacement, maternal pulse rate.
2.
2.
Highest priority would be your temperature, right. A client, 39 weeks gestation, fetal heart baseline at 144, tells the admitting labor and delivery room she has had her to wear a pad for the past 4 days because I keep leaking urine. Which of the following is an appropriate action for the nurse to perform at this time? Palpate the woman's bladder to check for urinary retention. Obtain a urine culture to check for urinary tract infection. Assess the fluid nitrazine and see if the paper turns blue. Percuss the woman's uterus and monitor for ballottement.
Number 3.
Yes. The nurse is to intervene when caring for a laboring client whose baby is exhibiting signs of fetal distress. Which of the following actions should the nurse take? Administer oxygen via nasal cannula. Place the client in high Fowler's position. Remove the internal fetal monitor electrode, or increase the intravenous infusion. Whoa.
Jamie says 1.
There's fetal distress. Which of the following should the nurse take? Administer oxygen? No, because it says nasal cannula.
Number 2.
That would be Side or Trendelenburg, not high Fowler's.
I guess it'd be 4.
Yes, 4. Increasing the IV rate helps to improve perfusion to the placenta.
Mm-hmm.
4 women request to labor in the hospital bathtub. Which of the women is at increased risk from the procedure? Women during transition. Women during second stage of labor. Women receiving oxytocin for induction. Or women with prolonged rupture of membranes.
4.
Why? Why?
Because of infection. She's been ruptured for a long time.
Yep.
And
And anything inside of that water can ascend. All right. Full-term client contracting every 15 minutes by 30 has had ruptured membranes for 20 hours. Which of the following nursing interventions is contraindicated at this time? Intermittent fetal heart auscultation, vaginal exam, intravenous fluid administration, or nipple stimulation.
When it says contraindicated, does that mean like we don't do it?
Right.
Number 2.
Number 2. They've been there for 20 hours, and every time we do a vaginal, there's an increased risk of infection. A woman 39 weeks gestation is admitted to the delivery room with vaginal warts from HPV. Which of the following actions by the nurse is appropriate? Notify healthcare practitioner for surgical delivery. Follow standard infectious disease precautions. Notify the nursery of imminent delivery of an infected neonate, or wear a mask whenever the perineum is exposed.
1. Oh, wait.
2.
2. Standard precautions. Just because they have HPV doesn't mean that they can't deliver. Depends
No,
if it's
but-
inflamed or not.
We said earlier that the warts could prevent.
If the warts are active. Remember?
Yeah.
Acuminata. Acuminata. That's the warts, because it's a warthog. The acuminata have to be present to actually cause the pelvic, not the pelvic, the soft tissue dystocia. Because HPV is a virus, it could be in remission. There could be no actual warts blocking. Don't add. Be careful. That's what we mean. We have to know the material. Be careful. Don't add into it. Didn't say it was active. All right. We're going to jump a bit because we can. And we like math problems. 48. The doctor writes the following order for a 31-week gravid with symptomatic placenta previa. Weigh all vaginal pads and estimated blood loss. The nurse weighs one of the client's saturated pads at 24 grams and a dry pad at 4 grams. How many milliliters of blood can the nurse estimate the client has bled?
Six? No?
Somebody wasn't good at math when they were in elementary school. If I have 24 cookies and I remove 4 of the cookies because they're plastic,
20.
Oh.
20.
That's just 20 grams. You haven't converted it to milliliters.
Mm-hmm. So we're still waiting. One gram equals 1 milliliter.
20?
20, yay! All right. 29-week gravid client is admitted to the labor and delivery unit with vaginal bleeding. To differentiate between placenta previa and abruptio placenta, the nurse should assess which of the following. Leopold's maneuver results. Quantity of vaginal bleeding, presence of abdominal pain, maternal blood pressure.
3.
Yay, we got 3. A client with complete placenta previa is on antepartum clinical unit in preparation for delivery. Which of the following should the nurse include in teaching session for this client? Coughing and deep breathing. Phases of the first stage of labor. Lamaze labor technique. LeBoyer hydrobirthing.
4.
1.
1. It's placenta previa, C-section. Get ready for the incision. They're not going into labor. They're not going into labor. They're not going into labor. Placenta previa, remember? An obstetrician declares at the conclusion of the 3rd stage of labor that a woman is diagnosed with placenta accreta. The nurse would expect to see which of the following signs and symptoms: hypertension, hemorrhage, bradycardia, hyperthermia.
Two.
2. Yep. You would expect hemorrhage with accreta. Told you there were more questions we haven't seen yet. Labor nurse is caring for a client 30 weeks gestation who is symptomatic from a complete placenta previa. Which of the following position order should the nurse question? Administer betamethasone, Celestone 12 milligrams IM daily times 2. Maintain strict bed rest. Assess cervical dilation. Regulate intravenous Ringer's lactate drip rate 150 milliliters per hour.
3.
I was going to say, don't make me stab you all. All of you shall be stabbed with a
Because
spoon.
she could rupture it.
Stab you all. Yes. Okay. Wordy. The nurse is monitoring a woman, G2, P1001, 41 weeks gestation, in labor. At noon, assessment revealed cervix 4 centimeters, 80% effaced, +3 station, and fetal heart rate with a moderate variability. At 5 p.m., assessment, cervix 6 centimeters, 90% effaced, and +3 station, and fetal heart rate with 120 with moderate variability. At 10 p.m., cervix 8 centimeters, 100% effaced, and +3 station, and a fetal heart rate of 124 with moderate variability. Based on the assessment, what's the following should the nurse conclude?
1.
Labor is
Yeah.
progressing well.
I agree.
I agree.
This is 53. No, it is not 1. Doesn't really matter, so we're just going to do this.
2.
There you go.
-3? I thought they were both +3.
All 3 of them will be -3.
Oh, well, then that changes it.
Yes, it
Yeah.
does.
Yeah.
Sorry about that. -3 station. How does that change it?
It's not coming down, so a big baby.
Yep, big baby. After a multiparous woman has been in active labor for 15 hours, an ultrasound is done. The result states the obstetric conjugate is 10 centimeters and the suboccipitobregmatic diameter is 10.5 centimeters. Which of the following labor findings related to these results? Ooh, you have to know your terminology. Full dilation of the cervix. Full effacement. Make sure I have the right number on this one. Station of -3. Or frequency every 5 minutes.
Number 3, because it's sub.
Yep, it's a big old head. High station is consistent with the data in the scenario. All right. During a vaginal delivery, the obstetrician declares that a shoulder dystocia has occurred. Which of the following actions by the nurse is appropriate? Administer oxytocin intravenously per doctor's order. Flex the woman's thighs sharply towards her hips. Apply oxygen using a tight-fitting face mask. Apply downward pressure on the woman's fundus.
It's not on the fundus, it's the suprapubic area. Two.
It is 2. Flex the woman's thighs sharply back towards it. What's that called?
McRoberts.
McRoberts. All right. The fetal monitor tracing of a laboring woman who is 9 centimeters dilated shows recurring late decels to 100 beats per minute. The nurse notes a moderate amount of greenish-colored amniotic fluid gush from the vagina after practitioner performs an amniotomy. Which of the following nursing diagnosis is appropriate at this time? Risk for infection related to rupture of membranes. Risk for fetal injury related to possible intrauterine hypoxia. Risk for impaired tissue integrity related to vaginal irritation. Risk for maternal injury related to possible uterine rupture.
Infection?
This would be for the baby because the baby could breathe in or suck in, right?
Toxic? Well, it's light deceleration, so 100 beats per minute. That's bad.
So what are we saying?
I'm gonna go with 2.
And you'd be right. What is that greenish stuff probably coming out?
The first poop.
Meconium, right? Fetal injury related to possible. We're not worried about infection because that takes a little bit longer. We're worried about right now. At this time, we're worried about that. All right. We'll get to 60 and then we can call it today. Which of the following clinical situations would be appropriate for an obstetrician to order a labor to perform an amnio infusion? You need to order a labor nurse to perform an amnio infusion. Placental abruption, meconium-stained fluid, polyhydramnios, late decels.
Two.
Yes. 2, meconium-stained fluid. What does that do?
Well, the amnio infusion will just kind of help dilute it a little bit.
Yep. They'll break it up.
Adding more fluid in.
A nurse is monitoring a client who is receiving an amnio infusion. Which of the following assessments is critical for the nurse to make in order to prevent a serious complication related to the procedure? Color of the amniotic fluid, maternal blood pressure, cervical effacement, uterine resting tone.
Would it be color?
Why would that cause an issue?
I just realized I'm on mute.
Why would it?
Yeah.
Infection?
Uterine
Color.
resting tone.
We're looking for a complication to the procedure.
Oh.
Uterine resting tone, right, Jenna? Because if you
You don't
go
wanna
into that, you may cause preterm labor or premature labor, or both.
Or too much uterine distension.
All right. 60. During the delivery of a macrosomic baby, the woman develops a 4th-degree laceration. How should the nurse document the extent of the laceration in the woman's medical record? Into the musculature of the buttock, through the urinary meatus, through the rectal sphincter, into the head of the clitoris.
Number 3.
Yep, through the rectal sphincter. All right, so we have finished up our 2 hours on this. Let's see. Off. Save that. So we finished up our 2 hours on this. We'll have more of these going up, of course, but this is our first one, so I'm going to end the broadcast now.